Today we have Dr. Ejiro, pharmacist, pharmacist, Chidibere, and then Oyebisi. We are all in the team, the same team. So we have an outline of the applications. Next slide. We have introduction. That is the content of the outline. We have introduction. I've not read it. Okay, we have introduction to statistics. We have population and sampling. We have variables and measurements of data. We have scales of measurement. We have descriptive statistics. We have epidemiological statistics. We have common use of epidemiological statistics. We have types of study design, which could be experimental, non-experimental. We have also designed an analysis of clinical data. Next slide. Next slide. Okay. Statistics as an introduction is a tool we use in pharmacology research. And then we use it equally in industrial research. We use it in clinical research, in the hospital, in the community pharmacy, to summarize experimental data in terms of central tendency and variance. We use statistical analysis when we have taken an experimental studies. We use statistical analysis to get our central tendency, variance, even mean, median, and mode, to enable us to conduct a hypothetical testing. Then clinical practice and pharmaceutical industry make a decision based heavily on empirical evidence, especially in the development of new drugs. Like in clinical pharmacy, in collaboration with industrial pharmacies. Without industrial pharmacies, we cannot actually practice clinical pharmacy because we need the drug substance. We need the drug itself being manufactured, and we need the clinical application by using the drug. And then in development of new drugs, we need application of statistical analysis so that we'll be able to know how effective these drugs are pharmacologically in the system. Then to know which one is of more superior to the other that we should be used. Therefore, it is essential for pharmacists to have understanding of the uses of statistics. We use it daily in our application, day-to-day application. But this time around, we are targeting pharmaceutical product and pharmaceutical analysis and clinical pharmacy. We have population and sampling. Population has to deal with the entire, when we talk about population, it is in a study, we have to look at the population, and then we look at sampling. Sampling is a fraction of population of interest. So when investigating a particular research question or hypothesis, a researcher must first of all define the population to be studied. It's just like when you have to determine the availability of medication or availability of medicine or drugs in emergency unit, you need to have a research question, a hypothesis in a given in a study group or population of those emergency unit, so that with your questionnaire checklist, you'll be able to check your list using those research questions. Then population refers to any set of objects in the universe. Population too can be defined in a specialist hospital, whereby we have different units of, we have different specialties. We have urology, we have oncology, we have different units in the specialist hospital. We need to define our population group in terms of generating our questionnaire to a target population. Let's say like in a prostate case of a patient, whereby you want to know the quality that is the process quality life of patient in oncology or in urology department, you need to define your subject. That is your set of objects when you are carrying out population. Then sample is just a fraction of a population. Sample can equally be like a subset of a population, not the entire population. When you are carrying out analysis, you don't carry the entire population in an environment. It's just a subset that a fraction of a sample is a fraction of a population which you will use. Then samples are chosen to make specific generalization about the population of interest. You take out a sample, you choose a sample for a specific generalization of a population of interest. You don't take the entire population, but you just take a sample so that you'll be able to use that sample to make a general statement on that specific population of interest. That is why sample should ideally be chosen at random, and each member of population must have equal probability of being included in the sample. Next slide. Next slide. Random sampling can be randomed number in tables, stratified randomly, or clustered random, or systematically random, or convenient randomly. I can explain that of random sampling. When you are talking about random sampling, it's not every, you just take randomly, maybe in a particular, when you are taking random sampling, just like you are carrying a study on availability of a drug, emergency drug in a reputable hospital, like teaching hospital, federal medical center, specialist hospital, and reputable standard private hospital. You take it randomly to be able to carry out your analysis correctly. Then even cluster random, and then stratified randomly, and then systematic random sampling, and convenient random sampling, depending on the kind of studies you are carrying out. There are studies like clustered random sampling, when you want to maybe take a patient counseling in you want to take maybe patient counseling, you want to now study the population of a patient counseling within a particular hospital, in a particular state, or in a particular area. You can do a cluster sampling to be able to know whether actually the pharmacists that are involved in those practice are actually doing their work well. Next slide. Variables and measurement of data. It is good as a pharmacist to have understanding of variables. Variables are characteristics that are being observed or measured. Variable can be observed or measured. We have types of variable: dependable variable, independable variable, and confounding variable. Then we talk about data. Data is a measure valued assigned to the variable for each individual member of the population. For example, a variable will be the participants in biological sex, while the data is whether the participant is a male or female. It is good to have understanding and to know the difference between a variable and a data. Data is measurable value assigned to the variable of each individual member of the population. Next slide. And we have scales of measurements. We have scales of measurement. We have 4 scales of measurement. We have nominal scale, ordinal scale, interval scale, and ratio scale. Nominal scale is not ranked. Example, we have gender, male and female. like students in the classroom, maybe pharmacy students in 200 level, you can take a nominal scale of such students, which is qualitative data, for you to be able to know their mean, their median, and mode. The male student could be like 100, and then the female student can be maybe 150 students in maybe 200 or 300 level undergraduate study. With that nominal data, you'll be able to know their mean, their mode, and their medium skills or data in the class. Then that is male versus female. We can take the gender or transgender. Then ordinal scale. Ordinal scale is ranked, is named, it is grouped. It is being observed. It is either qualitative or quantitative. It is either qualitative or being quantitative. Example of ordinal scale is just like, how satisfied are you with a particular product in a pharmaceutical industry? Let's say example, Mega Life pharmaceutical product, solid inflammatory, anti-inflammatory drug. You want to carry out analysis, application of this medication, whether people that are placed on this drug are totally satisfied or satisfied, they are neutral or dissatisfied or totally dissatisfied. You can have this ordinal scale as a measuring parameter to be able to quantify those kind of studies for those that have maybe placed on such medication in the hospital, to know those are really satisfied, totally satisfied, satisfied, and neutral and dissatisfied, and totally satisfied with the medication. Then equally, like the services we render as pharmacists, the services we render, how satisfied are the patients with pharmaceutical care? Those are ordinal skills too that can be used. How satisfied are patients with pharmaceutical care? Are they satisfied? Are they very satisfied or satisfied? Are they neutral or unsatisfied or very unsatisfied? You can use those skills to measure those parameters. Then interval scale. The interval scale, it's a variable which is quantitative measure. It has a constant interval, which is either additional or subtraction. Like someone who has 30 years of age old is as half as 60 years of age. Or you can use even temperature to measure. Somebody that is maybe 10 degrees Celsius to 5 degrees Celsius, you can find out the difference between somebody that is 15 to 10. You find that the differences, the interval will be constant. It will have a constant interval between the two of them. Then ratio. We also have characteristics of ratio too. Ratio is absolutely 0 points. Temperature on Kelvin scale. Next slide. Next slide. Variable, we have continuous quantitative variable. Generally consists of data measured in interval or ratio scale. Continuous variable, which is quantitative, body mass index, which most of us in the hospital, at least with this pharmaceutical care, and then most of us that have gone through Doctor of Pharmacy in UniBen, when we are doing our clerkship, we take body mass index of our patient, which we equally made to understand that even our systolic and diastolic blood pressure too can be measured, which is a continuous variable. Then categorically discrete or discrete variables consist of data that are measured on nominal or ordinal scales, because the scales of measurement are natural. gender, race, then blood pressure status. Next slide. Descriptive statistics. We had descriptive statistics, we have inference statistics. So whatever study one is carrying out, you should be able to know whether it is descriptive statistics you are going to apply or inference statistics. Descriptive statistics is organized and summarize variable data by providing information regarding the appearance of the data and distributional characteristics, measurement of central tendency, variability, shape, histograms, and scatter plots. Descriptive statistics, by you measure, you have to have an organized data in summary. That is summary, that is in average, in mean. You have to take your mean, then you're able to get your central tendency. Then you do your histograph. Once you have your histograph plot, you'll be able to give proper description of your descriptive statistical analysis. Then inference statistics indicate whether differences exist between groups of participants or whether an association exists between variables. It is used to determine whether the difference or association is real or whether it is due to some random process. The statistics produced by statistical tests, such as the I statistical produced by t-test. Inference statistics, the t-test will give you whether there is a relationship between the ideal and variable or value with the one that you generated. If there's any relationship, the p-value will tell you whether there's any relationship, significant relationship or non-significant relationship, by the time you have your data well coordinated. Next. Epidemiological statistics. Diseases are distributed in population and various factors influencing the distribution, and they're not unique to the field of epidemiology as much as of the literature in the biomedical science incorporates in some of these statistics, such as odds ratios. Basic level of understanding of these statistics is important. It is good we have understanding of basic statistics and then how to use it when due. Common used epidemiological statistics, incidences and prevalences. Incidences quantifies the occurrence of an event or outcome over a specific study period within a specific population of individuals. Prevalence quantify the number of people who have already experienced the event or outcome at a specific time point. The ratio, proportion, and rates used interchangeably in medical literature without regard for the actual mathematical definitions. Next. Commonly used epidemiological statistics, relative risk and odds ratio. Relative risk is the ratio of incidence of an event occurring in an individual exposed to a stimuli compared to an incident on event. In those not exposed to the stimuli, odds ratios are used when compare event to non-event, which is calculated depending on the study design. You know, the study design could be experimental and non-experimental. If it is non-experimental, it depends on the studies you are carrying out, then you'll be able to apply this relative risk and odds ratio rates. Then sensitivity, specificity, and predictive value, all like sensitivity, specificity, and positivity and negativity value indicate the ability of a test to identify correctly those experiencing the event and those did not. That is, this specificity is mostly applicable for experimental studies because study design will determine the kind of statistical analysis you carried out through. Next. 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 Types of study design. We have experimental design. In the biomedical sciences, experimental design typically referred to as randomized controlled trials. So for those of us in pharmacology, for those of us in the industry that has to develop a new drug, for those of us that have to carry out experimental studies, we need to go along with randomized controlled trials to do our experimental design, to carry out those analysis using those randomized controlled trials. Then quasi experimental design are used more often in the social sciences, but they can be observed in the biomedical literature on the surface. This type of design appear to be experimental. However, they lack one key aspect: randomized assignments. Non-experimental design. I will dwell more on this non-experimental design because when I did my PharmD, I did non-experimental design. Even my master's now, I'm doing non-experimental design. The non-experimental design is mostly like questionnaire checklist. Yeah, you have a questionnaire checklist, and then you go into the clinic or hospital where you are carrying out your studies. By the time you have approval from the research ethical committee of the clinic or the hospital, a reputable hospital, then you now go in to collect your data. Just like I talk about determination of essential, that is essential emergency drugs. You have the classes of drugs are arranged pharmacologically, and then you now carried out through the research committee, you're able to get your data, and then you now sit and analyze your data. If it is one you can do manually, but mostly you have to go to SPSS sometimes to now get the actual table of context of what you are doing. Then you'll be able to make quick interpretation and it will save your time too. Non-experimental design have several advantages over randomized controlled trials. Primarily, lower cost. Yes, because it's not dealing with chemical and all those things. It's just for you to get your questionnaire approved by your supervisor and then the ethical committee, and then you now go in to do to carry out. Some will warrant you seeing your colleagues in the pharmacy, and some, like the one I'm doing for masters, I did not need to see. The research committees between me and the patient, and then the consultant urologist in the specialist hospital. A quick timeline to publication and a broader range of participants. Well, the studies I'm carrying is about 200 patients for the one I'm doing now. Then design and analysis of clinical trials. In the US, National Institute of Health define 5 different types of clinical trials. In the United States of America, National Institute of Health define 5 different types of clinical trials: by treatment, by prevention, by diagnostic, by screening, and quality of life. Like the one I'm doing now is the quality of life of prostate, to determine the quality of life of prostate patient in the specialist hospital. Then the design of clinical trials, parallel group design. Most common randomized controlled trials, independent variable, typically involve participants randomized into fixed level of treatment, also known as treatment arms, with each arm indicating a different treatment comparison. Then cross design. Second most common randomized controlled trials, primarily advantage of each participant serving as his or her own control, with lesser participant compared to the parallel group design. Adaptive design. Most recent advancements to the randomized controlled trials, also called ACT. Briefly, ACT implements changes adaptation in the design of the study based on the result of the predetermination set of the interim statistical analysis. Next. The analysis of clinical trials. By the time you have two analytical approaches exist for clinical trials, intent to treat and then to protocol approaches. The ITT approaches is often employed in the presence of violations to protocols or patient being lost to follow-up. ITT require the analysis to include all participants in the arm to which they were randomized originally. That is treatment of effect and best evaluated by the planned treatment protocol rather than actual treatment given. By comparison, the PP approach evaluates only complaint participants with complete data. Next. For later consideration, statistical inference, sampling distribution, and central limits, theorism, hypothesis testing error, and statistical power. Statistical tests, non-parameter tests. Okay, the test one is subjected to after collating your data. You are subjected to maybe carry out, it depends on the instruction given to you. Either you use statistical tests or statistical versus clinical significance. Then from there, you'll be able to interpret your results, and then survivor analysis. You'll be able to interpret your results accordingly. Next. A thorough understanding of statistical method is integral to effective evaluating medical literature. Being conversant of the effect study design has on result, interpretation, and generalization is incredibly important to implement evidence-based practice. Statistical analysis are simply a piece of puzzle when evaluating literature, since the study design and research question determine the appropriate analysis. That is why, see, depending on the studies you are carrying out, and then the research question, it will now determine which of the tests you will subject your research questions to, so that you'll be able to get your correct answers, and then you'll be able to interpret even your result. It must be noted as simply because a study is published does not define it as a qualitative study. Further, all research has flaws, some trivial and others significant. Next. Thank you for listening.
Hello?
Hello.
Thank you very much. I was just smiling all through. I told you you'll be able to do it.
Okay.
Thank you very much.
Yes, sir.
I want to thank Dr. Florence for a wonderful job. In fact, she said she was only going to take the first 7 slides, and then I will have to continue. But interestingly, she practically ran through everything. Thank you very much. So
yes, Doc.
I would just basically, sorry, let me stop sharing and then go back to the slides. Just a minute, please.
Okay.
I'm trying to go back and repeat. I'll just do a little overview and clarifications on some of the points. Okay, I'm almost there. Just a minute, please. share. Okay, just quickly, I want to quickly run through the sampling techniques, because at the Research Ethics Committee, we pay particular attention to the sampling of your study, but to be able to be sure that you are to a large extent minimizing bias. So like we saw from the presentation already done, we have 5 random sampling techniques. Even though it is termed random, it doesn't mean that the presentation, the study or the research is haphazardly done. Now, when you have a target sample, a target population where you want to do your study, say you are taking a look at diabetic patients. Let's say you have N number of patients. So the patients are numbered 1 to N, and you require 200 patients as your sample size. Now there are random number tables which you can get online. You have packages for them. Now the random number tables assign numbers from 1 to N randomly. So with that number, if you are to take a look at 200 diabetic patients in a particular center or a local government, for instance, in a set population, the numbers assigned from the random number table, those are the numbers you use to pick, for instance, the patients coming to the diabetic clinic in my center. And if my random number table generates these random numbers, say number 1, number 5, number 15, number 21, it means that for the patients coming to the hospital, if I pick the first patient as number 1, the next number generated by the random number table, I pick that number. So that to a large extent minimizes bias. So even though it is called a random sampling, it is not haphazard. So you could use a random number table, which you can get online, to generate the random numbers on the basis of which you pick your samples. Then you could also have a stratified random selection. Now, what this simply means is that within this set population you have selected, you could stratify in terms of sex, in terms of race. For instance, I'm looking at the diabetic patient. I could say, okay, the female diabetic patient, a male diabetic patient. You've created 2 different strata. And then we'll take a look at, you do your analysis, your sampling and analysis following that. You also have the cluster random sampling technique, where we are looking at, for instance, diabetic patients again, counseling of that. You take a look at the counseling techniques in the eastern part of Nigeria, the northern part of Nigeria. If we have, as a result of our culture, we have different ways we talk to counsel our patients. Then looking at the patients in one region becomes a cluster. Looking at the patients in another region becomes another cluster. And then we'll analyze the results in these various clusters to see if there are differences. You could also have the systematic random sampling techniques. In systematic random sampling, you could have, it's usually based on registers. We could say we want to take a look at the diabetic patients attending clinic in the DELSUTH. Now I go to the nurses register, right? I look at the register where you already listed the patients on the register. Now I can pick a particular patient and take that as my first patient. and then decide that every nth patient will now be included in my study. I could say every third patient. So from that patient I have picked systematically on the register, I picked the third or the fifth, depending on which I have decided to use in that systematic random sampling. So I don't just look at the name and say, no, I like this name. No, I have decided that once I take my first patient on the register, every 5 patients I'll pick. That now becomes the systematic random sampling. Or you could also have the convenient random sampling technique. I can just decide to say, okay, I want to take a look at patients coming to the DELSUTH alone. So conveniently, because I work in the DELSUTH, I just look at only the patient coming to the clinic in DELSUTH to do my studies. That's convenient for me. So those, even though we say random sampling, it doesn't mean it is just haphazard. It follows set patterns. I think she basically covered all that we need to in this short time. However, there is a whole lot that we can take a look at in statistics. And that is why for further consideration, we said there are 5 other topics that need to be dealt with. And these include statistical inference, statistical test, statistical versus clinical significance, and survival analysis. And for each of these major themes, we have sub-themes. For statistical inference, you have the sampling distributions and the central limit theorem. You have the hypothesis testing. You have the error and statistical power. For statistical tests, we have the non-parametric test, the Pearson's chi-square test, the Fisher's exact test, the Mentel's chi test. All of these tests have specific relevance in biomedical research. And these, in the course of our training, we want to spend more time on. So at this point, I want to say thank you to all those that have been present, and thank you very much to Dr. Florence for, and I want to release one secret. This, we launched her into her first presenting in this platform. Thank you very much.
Thank you.
So I want to hand over to the moderator now.
Yes, I want to thank Dr. Florence and Dr. Ejiro for this wonderful presentation. It is very excellent. It's very brilliant. I really thank you all for doing this great thing. And this is encouraging for other people to come in. I know this aspect, first, that it's not easy for anybody to crack. I have done a great job cracking it, encouraging other people to follow you. You see, people are afraid to read and come and present. Believe in me,
yes.
This is just about 6 out of about 27. There's no way you can have this to study. This is a very great area for all of us in pharmacy practice. Please let us encourage ourselves.
Very interesting.
Let us encourage ourselves. People are running away. When we say tell people to come and handle a topic, people will run away. Who will do it for us? Who will study for us? We need to encourage ourselves to study for ourselves, just for ourselves. You see, you people have really done a great job. We are really grateful and we appreciate your effort. It's a great one. So the floor is now open for people to make contributions, comments, to have. And I see Dr. Suleiman. Can you go ahead and unmute yourself and ask a question? That's Suleiman. You are free to. The floor is open. Thank you.
Good evening, everyone.
Good evening. You're welcome.
I want to first of all appreciate the presenter and the team that have also come together to put this. It is another eye opener, like the moderator has said. The area in which I actually want to chip in or probably ask the question is on the issue of data analysis, especially an average scientist and a pharmacist in particular. We are more comfortable with quantitative analysis. And I have seen with the little training I've received that there are a lot of parameters, variables that are actually important to us as a pharmacist, and especially in public health and co that are qualitative in nature. And then I have also read some papers where people will claim, in quote, that they use both qualitative and quantitative analysis in this in their research. But you find that all what they have done is only quantitative. There's nothing, they do not actually use those modem or method of analyzing the qualitative parameters in such studies. So I do not know whether this presentation do actually not cover the scope of the qualitative analysis, or we are not supposed to, in biomedicals or in pharmacists in particular, to go into qualitative analysis. Maybe it was meant for another group. I actually just wanted to, because it's an area which, after going through about 3 or 4 trainings, I found that we have a lot of information that can shape some policy, but we always dodge it because we were not trained as pharmacists or as scientists to delve into the qualitative analysis of our studies. Thank you.
Okay, Dr. Ejiro, Florence, can you respond to that query?
Okay.
Okay.
Dr. Florence, you can go ahead.
Okay, the qualitative analysis, like example now, the scale of measurement, that is a nominal scale, which I give example of a pharmacy student, undergraduate or postgraduate. That is, you want to know the, like, students in the class, male versus female. You can, once you know the total number of male to the student, like 200, 300 level or postgraduate student in the class, you can be able to get your mean, media, and then mode. And you can equally draw a histogram of those postgraduate students, and equally even pharmacists that work in your facilities, like pharmacists that works maybe in an institution, tertiary or institution where you work. You can be able to do those nominal analysis of those pharmacists maybe per period of 6 months, 12 months, or 3 months, like that. From time to time, like that, you can be able to do those analysis now. You can be able to check them.
Okay, Dr. Ejiro,
Okay. Yeah. The nature of most of our clinical work tend to be what's it called now? Just escaped them. Yes, it is possible in biomedical research to actually do both qualitative and quantitative analysis. But again, it primarily depends on the research work you are undergoing, what you are, the study you are doing. That determines the type, whether you are doing qualitative or quantitative. But we realize that because of the nature of most of our research work, we tend to do more of the quantitative analysis and less of qualitative. However, if we are to do, if we focus a lot on, by the time we do more of impact research, by that I mean you are working with the patient, you are collecting samples. I was once with Professor Nnatsu, where he worked on the clinical cure rates and parasitological cure rates in malaria therapy. In such kind of study, you definitely have to do both. You cannot just be, because there you are taking blood samples at intervals. You are having to determine if the parasite is still present or not. Not just only looking at the patient's relief of symptoms, which you can capture with questionnaires and all of that. So by the time you are doing such work, definitely you have to do qualitative analysis. It will not just be quantitative. So the nature of our research, the nature of the work we are doing will have a role to play in the kind of analysis we are doing. We get involved. And because of the time frame for this presentation, we cannot in-depth cover these topics in-depth. So this is just an eye-opener. It's just to introduce us to the topics. Each and every one of us want to, like you rightly said, you've been part of two trainings. We want to train ourselves in biomedical research, because the quality of our research work is a function of our study design, our method of analysis, sample collection, method of analysis, and all of that.
Thank you, Dr. Ejiro, for that attempt, Dr. Florence. Is that okay by you, or do you have anything?
Yes, it is okay. I have an addition.
Please,
and I actually want to say that what the last two speakers discussed, we are still purely quantitative. The qualitative aspect of it were actually not, like I said earlier, there was a training in Malawi that even me, after my presentation, I knew that I actually presented a quantitative in qualitative manner. And after going through the training, I understood that, look, there are different ways and manners that we need to carry out. By the time we have the training, we're definitely going to see the distinct difference between qualitative and quantitative. We create the indulgence of the organizer, that if I can get in touch with Prof in Malawi, and if by God's grace he can give us some days to take us through the level and some other measurements of qualitative, we will definitely see that they were two different things entirely. Just that they are more or less being used in the humanities. But like I said, they can as well shape the policy making in earth sciences. These days, that is what is being used in some society that believe that the perception of the patient is also paramount. How do you measure it? It is not a question of binomial or because you cannot say that 3 boys said yes and the 4 boys said no. That means that so because it is still quantitative, but then there are measures of measuring the perception and the data, and that is what I think. If we also go deep and deeper into it, we will definitely going to appreciate that with it will make our work quality in nature and quantity in appearance.
Thank you very much, sir.
Thank you, Ademola. We are going to get in touch with you as regard the lecture by the professor from Malawi. So I will see you after the lecture by God's grace to arrange for him to come around in one of our lectures. There's a question by the pharmacist Jonathan on p-value. He said, what factors can help a researcher estimate a good alpha value? He said p-value always set as less than 0.05. Then what factors can help a researcher estimate a good alpha value? Can you see it is in a message sent to us on p-value? The question is,
can help a researcher estimate
it's not that clear. Do you understand that? Maybe you can answer to that. So what factor can help a researcher estimate a good alpha value? Any response to that? So, Florence, Ejiro.
Can I chip in?
Please come in, please. You have the floor.
Yes, like p-value, like the presenter said, there are times you do research and it can be on the surface that based on the number of the responses. 30 said yes, 12 said no. And then you, after finding the mean, mode, and media, which you can use in getting your result out of it. But when you want to go into assessment proper, whether the statement is actually significant or not, p-value statistically is set at less than 0.05. Yeah. But then in some researches, you can actually go below that. For instance, if we actually wanted to look at the value by the NAFDAC in relation to a certain drugs, the significance can be set at less than 0.01. After carrying out your research and you test the confidence interval, which may actually be equal or less than 0.05, you can conclude that statistically it is insignificant. But that product has actually failed because the value of the NAFDAC it is 0.01. So anything above 0.01, we definitely so statistically, p-value of less than 0.05 is statistically significant, and which can make you to reject the null hypothesis and accept the alternative. But then when you are looking at it in research form, in relation to the value of the NAFDAC, I'm just using that as an instance, that I've said that any of this that fall below 0.01 or above 0.01 can actually not be registered as a product, because, and then it can be looked into, for instance, they may say that if more than 0.01% of the population reacts to these drugs, then definitely the drug does not pass, even though statistically it is less than 0.05. So p-value is actually bring us the true reflection of the outcome of your hypothesis that you have actually conducted. Like I said, maybe by the time we go into the lecture of hypothesis and the confidence interval, we'll be able to understand it more.
Thank you, Dr. Wadimala, for that one.
Thank you very much, sir. So, in direct answer to the question, as significant p-values always set at less than 0.05, the answer is no. However, most times at confidence interval of 95%, p-values are set at 0.05. So when you have p-value less than that, then that is where you say you have significance.
Thank you, Dr. Ejiro, and Dr. Ademola, and Dr. Florence. So, do you have any comment, any contribution? Because we are about to round up for tonight. Any additional information, any comment, any contribution? We have just 2 more minutes or 4 to go.
Hello, sir.
Okay, Dr. Ademola. Okay.
Yes, this lecture has certainly shown us that we still have some things to go through, because if you understand the lecture we had yesterday at a CIPA, which has to do with the issue of research, we just don't jump into research if you also do not have the details of the ingredients that we need to put together to make us to publish. And they have also actually shown us the way to go by this presentation. So I think the organizer should also let us have a piecemeal. If you have piecemeal of step by step of what we need to go to, by the time we have 5 to 6 to 10 lectures on those piecemeal, each and every one of us, by God's grace, will be experts in research, and then we can conveniently and comfortably publish.
Thank you.
Hello, Dr. Ibrahim.
I agree totally with that suggestion.
Hello, Dr. Ibrahim.
Pharmacist, please go ahead. Please.
How are you, sir?
Fine, thank you.
Yeah, good evening.
Good evening, Pharmacist.
I want to give my kudos to the two presenters and the contribution of Demola so far. Thank you very much. Pharmacist Demola, how are you?
Fine, sir.
My own little submission is that I want to align myself with the submission of Pharmacist Demola in the fact that, you know, this thing is statistic, and sort of, so many people are afraid of mathematics. In fact, when we are in school, not all of us will want to dabble into the aspect of mathematics, why not? Because it is compulsory. But nonetheless, as scientists, we've got to exercise some bit of patience in going through this topic. And whoever is going to lead us in any particular topic, I want the and not just theoretical aspect of it. It is good.
Hello, network. Sorry.
Looks like he's having network issues.
So one might not be able to understand it more.
Sorry, you have a network challenge. You can
I think that is just my own.
Okay, thank you. Do we have a network issue? We can't really understand your...
Yes.
Sorry. So we get you.
I think he was trying to say that we should be more practical than the theory running through. So we can take each subsection and practicalize it in practical terms. As for the calculations, we actually have a lot of software now that can help you do these analyses. So we may not be doing the plus and minus again. However, it's important that we understand when to do what and the meaning of each. So if it's possible, we'll get a journal, an article, and review it and apply each of these and see how they apply to that article. That will we appreciate more.
I think that's a very good, because we have done module 4, module 5, and module 6. They are interrelated. So, and the next is now to critique biomedical literature, to look at the designs and everything together. Because those 3 modules work together for us to be able to evaluate the biomedical literature. So we'll look into that aspect too. The purpose of this training is just to kind of prepare us. Like he said, it's an eye-opener for us. So we're just starting. The journey of 1,000 miles, we start with a step. It's just a step towards the better height that we're looking at. So we understand you, Dr. Afisa. So at this point, we want to thank everyone for coming. Pharmacist, you have a question, please. Pharmacist, you can go ahead, please.
Hello, sir.
Yes, you're welcome.
Yes, sir. Thank you very much for this initiative, sir. I really appreciate it, and I'm learning a lot. Though it's coincides with another meeting at my place of work, so most of the time I listen to the recordings and I learn from them. For my comment this evening, I've missed this one too. I'm just joining like 10 minutes ago. But from what I've heard so far from the comments and everything, I think it's a good thing because it's an eye-opener. And I'm thinking that if we're well learned here, probably a multi-center study, we can team up maybe to do a multi-center study. So we'll have the same protocol and everybody will be carried along in a way that what is happening in DELSUTH or in maybe UTH or in different hospitals, what is happening in Lagos in Ogun State. So that would also help us to learn better because it's something you'll be involved in from the beginning to the end, based on the fact that you are taking charge in your own institution. Thank you.
Thank you, Pharmacist Christiana, for that one. all our comments and contributions are noted. So we have on them. So at this point, I want to call on a pharmacist, Florence Adule, our acting coordinator, please, to give the closing remark. Pharmacist Florence Adule, FPSN. If you're still online, can you please go ahead and give us the closing remark, ma'am?
Good evening, distinguished colleagues.
Good evening, yeah.
I'm sorry I joined,
No
I joined late, but the much I heard, it's a lot of inspiration and encouragement, and I'm particularly happy that we are doing all of this. I want to thank and appreciate tonight's lecturers. You did great job. And even some of us that are not too much into research like that are able to follow you. Thank you very much, and God bless you. Thank you to all participants. Without you, it would have been so boring. And we thank you for making out the time. We know that this is a very critical period, having just gone through a conference and all that. So we are all tired, but you still made our time to come. God bless you all. And we pray that all of this will lead to upliftment of our profession. Thank you, and God bless you.
So thank you, ma'am, for that one. So at this point, we want to say goodbye for now. And another day is another time. Thank you for all coming, for joining. So please go ahead and prepare for your own turn. You have other modules to go ahead, and we have our groups. Go to your groups, prepare for your own time. So to give us something as good as this one. Good night, everyone, and time for coming.